Exam 4 is all about the immune system. First, we talked about the nonspecific immune system, also known as the innate immune system. This is when we have an immediate but generalized response. Then we talked about the adapted or acquired immune system. That has to do with a specific response, and we talked a lot about antibodies in that chapter. The final chapter, we talked about immune disorders. So we talked about allergies, autoimmune diseases, and then deficiencies in the immune system. So, first up, we're going to talk about the nonspecific or innate immunity. So, this is when we have a general and immediate response. So, it doesn't really matter what it is, if it's viral or if it's bacterial, the body is going to respond right away to try to combat that pathogen. We talked about how our physical barriers, this is going to be that first step in preventing pathogens from entering in our body. So, skin, mucous membranes. Mucous membranes are going to be the easiest way for things to enter. We also talked about chemical barriers. So, we have lysozyme in our saliva and tears, which is antimicrobial, stomach acid, which is very acidic. Not a lot of things will live in stomach acid. And we talked about antimicrobial proteins like defensins, which almost act like a natural Purell. We also talked about our cellular defenses, so our leukocytes, our white blood cells, and the different types of leukocytes. We talked about inflammation, fever. Those are things that I think are a little more relatable. Some things that I think are a little harder to wrap our head around. Molecular defenses like acute phase proteins, complement, and interferon. I like to think that interferon interferes with viral infections. So, part of our cellular defenses are our phagocytes, our white blood cells. And we talked about how phagocytes will gobble up a pathogen. First, they have to find it. So, we talked about that chemotaxis. Then they have to bind to it. Then they have to ingest it. Then they have to digest it. One of the things that we talked about with binding is that sometimes bacteria can be sneaky, where they have that thick glycocalyx, where they're kind of slimy, difficult for those phagocytes to bind to them. That's when we talked about opsonization, so coating them so that it's a little easier to bind. The other white blood cells that we talked about were neutrophils. Neutrophils are in the highest number. They are going to be antimicrobial. So they're going to be lining a lot of those areas where pathogens can enter so that they can gobble up those pathogens. Now, once neutrophils will phagocytize those pathogens, they will die. So that's why we need them in such high numbers. Eosinophils, they help us combat parasitic infections. So helminths are too big for macrophages to digest and gobble up. So what they do is that they punch holes into that helminth, break it up into small pieces so that those phagocytes can gobble them up. Monocytes will circulate in the bloodstream. Then they'll migrate into the tissues and they'll power up to be macrophages. One of the things that I mentioned with macrophages is that they help us with long-term immunity so that when they gobble up a pathogen, they can actually display that pathogen antigen on its cell surface, almost like the storefront window, so that those immune cells can recognize those antigens. So we also saw those in our adapted or acquired immune system. Mast cells and basophils, they're going to release histamine. Remember that histamine is going to be that flare gun going off, calling in the cavalry and all of those white blood cells. We saw histamine during the inflammatory process. And then natural killer cells, I call these the ninjas. They're going to go around and give cells the kiss of death to get rid of them. So one of the ways that I have remembering how the quantities of these cells, I always remember never let monkeys eat bananas. The other cell that we didn't I didn't really put on here that we talked more about in our adapted or acquired immune system are lymphocytes. Then that's when we talked about our B and T cells that we'll talk about when we get to the adapted or acquired immune system. Now, where are these cells going to migrate? They're going to migrate in our lymph. So we talked about lymph. We also talked about lymph nodes. They're going to be scattered throughout our body. I think of those as being the conference rooms or the meeting places where those pathogens can then present what they found. We talked about the thymus. That's the training ground for T cells. Spleen, which is the largest lymphatic organ, tonsils, adenoids, and also the appendix. So those are our lymphatic organs. Something that I think is relatable because we've all experienced this on one level is inflammation. So the signs of inflammation: redness, swelling, heat, and pain. The reason that we get that redness and heat is because that blood is rushing to the area. So that histamine that the basophils and mast cells are releasing, that causes the blood vessels to dilate. Bradykinins also cause that as well. So that now those leukocytes can now get into the tissues. So it's kind of like calling in the cavalry. When we get all of that blood to the area, that's going to not only bring the immune cells, but also bring nutrients so that we can feed those immune cells. And then because those blood vessels become leaky, we end up getting that fluid buildup. That's what causes that swelling. That also kind of helps to wall off the area. So if any pathogens are there, they can't travel. So those are the 4 signs of inflammation. Something else that I think is also relatable is fever. So the clinical definition of fever is a temperature over 38 degrees Celsius. Now, what causes our body temperature to rise are pyrogens. So pyrogens can either be from the pathogen that works on the hypothalamus, or those pyrogens can actually come from those immune cells. Our hypothalamus is our internal thermostat. So when those pyrogens act on the hypothalamus, it resets our temperature. Why we want a fever is that it helps to inactivate some of those temperature-sensitive toxins, enzymes in the microbes. Now, of course, if we start to crank up our body temperature, our proteins are at risk of denaturing as well. So this is one reason why we don't want a runaway fever. It also forces us to rest and it increases our metabolism. I always think of that old adage, feed a fever, starve a cold. So we want to make sure that we're feeding those immune cells so that they can actually do their job. Then we started to get into some of those molecular defenses. I think these are a little harder to relate to because it's not something that, even if it's happening in our body, we're really even aware of it. So the one thing that we talked about was interferon. So I think of interferon interfering with viral infections. So we mostly talked about type 1 interferon. So in this picture, you can see that we have a cell and it's being invaded by a virus. Remember, viruses are going to be intracellular obligate parasites. So when they take over the host cell machinery, it actually trips this interferon gene. So when it's activated, now the cell is making this protein interferon. Now, this initial cell is a goner because the virus is taking over the cell. But that interferon travels to neighboring cells and then causes the neighboring cells to make antiviral proteins. So when that virus tries to enter, it's going to interfere with its protein synthesis. So those antiviral proteins are going to be interfering with how that virus can make its proteins. It's not going to be able to continue and make all of its parts. So this is interferon, which interferes with viral infections. The other thing that we talked about that we also saw in the adapted or acquired immune system is complement. And there's 20 different complement proteins, and I'm not going to have you know all of the complement proteins, but some of them can lyse cells directly. Some of them can opsonize, so make phagocytosis a little easier. Remember, opsonize means to coat. Some of them can also trigger those mast cells to release histamine in the inflammatory process. So we see complement in the inflammatory process. We also talked a little bit about complement and how antibodies can actually activate complement as well. The last thing that we talked about were acute phase reactants. Now, cytokines, these are immune chemicals. This is how the immune system talks to each other. These cytokines can travel to the liver and tell the liver to produce these acute phase reactants. So one of the things that we would see as an acute phase reactant are C-reactive proteins. These tend to increase with inflammation. They can also activate complement. Mannose binding protein, this kind of marks and targets bacteria with mannose in the membranes, makes it a little easier for those phagocytes to find them. Now, this isn't going to affect our cells because we don't have mannose. So these proteins can help to fight those infections. So then we got into the adapted or acquired immune system. And we first started off and then came full circle, finished the chapter talking about active immunity versus passive immunity. Active immunity means that we are making antibodies against an infectious agent. Passive immunity means that we are given antibodies. Now, both of these can either be natural or artificial. So with active immunity, if we had natural exposure, like getting the flu, now our body is able to recognize that pathogen and make antibodies against it. Or we could artificially be introduced to that antigen through a vaccine. With passive immunity, the only way that we can have natural passive immunity is passed from mother to baby. We can give artificial injections of antibodies if people have been exposed to things or if they are fighting illnesses. So we kind of came full circle with our active and passive immunity because we talked about that with immunization. Here's a little visual of active and passive immunity. Again, active immunity, we're actively making those antibodies, where passive immunity, we are being given those antibodies. Again, the only way that we can have natural passive immunity is passed from mother to baby. Now, with our active immunity, we came full circle and talked about how this is important with delivering vaccinations and immunizations and exposing our body to those antigens so that then if we see it in real time, our immune system is going to be able to mount a defense. We also talked a lot about our B and T cells, our lymphocytes. So B cells are going to mature in the bone marrow. So B and B for bone. And then T cells are going to mature in the thymus. So this happens during gestation. And this is when B cells and T cells learn to recognize self-cell antigen from non-self antigens. We talked about how we all have these self antigens, MHCs, major histocompatibility complex, that our immune system needs to recognize. So we talked about this training and how they undergo clonal deletion. So if any of those lymphocytes recognize our self antigens as being foreign, we want to delete those, because if they were to sneak through, then they could potentially attack our cells. Any cells that recognize foreign antigens, we want to keep those around and we want to clone those because who knows if we'll be seeing those antigens at some point in our life. So with our B cells, we talked about humoral immunity, which is also called antibody-mediated immunity. And remember, those antibodies are going to be specific. This is why we call this the specific immune system, because those antibodies are going to bind to epitopes, so those shapes on the antigens. Now, remember, we could actually have many epitopes on an antigen, which means that many antibodies need to bind. We talked about the different types of B cells. Plasma cells are going to be rapid firing off antibodies. Memory B cells, they help us with our long-term immunity. So in that first picture, you can see that primary and secondary response. The primary response is the first time that we see the antigen, and it's IgG and IgM that we see mostly. Then in the secondary response, this could be the second time that we see the antigen, or maybe it's the fifth time that we see the antigen. Because we have those memory B cells that have been hanging around, they're going to immediately recognize that antigen, and that secondary response is going to be bigger and faster. Now, the good news is that the antibodies also get even better at fighting their job. So hopefully, if we see that pathogen again, our body is going to be able to mount a very good response to hopefully keep us well, or at least to keep us out of the hospital. Now, we talked about how this primary and secondary response is the premise behind vaccine development. So we could be artificially introduced with that antigen through a vaccine. That would be our primary response. Secondary response would be if we were actually exposed to it in real time. Because our body had seen that antigen before, it's going to be able to mount that response. We also talked about the different types of antibodies. So immunoglobulins, they're going to be bound to B cells. Antibodies are going to float. And remember, it's those plasma cells that are going to rapid fire off those antibodies, like 2,000 per second. The way that I remember the types of antibodies is the word gamed. So there's IgG. This is going to be the main antibody in blood. IgA. This we're going to be seeing lining the mucous membranes. So if a pathogen were to enter, chances are IgA is going to be the one that it encounters. IgM, I call this the mother of all antibodies because it has those 5 subunits. We see that introduced in that primary response. IgE, this is going to bind to mast cells and basophils with that release of histamine. And then IgD, this is the one that is lesser known, that we don't usually see in abundance with healthy individuals. I'm not going to ask you to identify the structures of the antibodies, but you should be able to know a little bit about what they do, and where we would actually find them. So we talked about how antibodies work, and I think when I think about how antibodies work, I mostly think of this neutralization. So coating that pathogen with the antibody and kind of trapping it in a bubble so that pathogen can't bind to cells. If it can't bind to cells, then it's not going to do our cells any harm. We also talked about opsonization. So if we coat that pathogen with antibodies, it's going to make it a little easier for those phagocytes to bind to. And we also talked about antibodies activating complement and those 20 proteins we can see in that inflammatory process. Then we talked about the second arm of the adapted or acquired immune system, and this is cell-mediated immunity. Cell-mediated immunity is governed by T cells. Now, T cells are the intermediaries. Without T cells, we would not have a healthy immune system. T cells need to be presented with antigens, and these antigens can either be presented on class 1 MHC or class 2. Class 1 MHC we would see on regular body cells, so like skin cells, liver cells. Class 2 MHC we would see on immune cells. So this is why I call them professional antigen presenting cells. So things like our B cells or macrophages. So there's different types of T cells. And we mostly talked about our T helper cells or T sub H cells, as you can see depicted here, and our cytotoxic T cells. Now, T helper cells, they have a CD4 receptor that's only activated by class 2 MHCs. So when B cells find and bind to antigens, they're going to wait for inspection. So they're going to wait for those T helper cells to inspect them to make sure that what they found is bad. And then we're going to start to clone those cells and then make a lot of antibodies. Those macrophages can gobble up a pathogen and then display those antigens on its class 2 MHC, and those T helper cells can recognize that as well. So that's why I call them professional antigen presenting cells, because they're part of the immune system. And our T helper cells with CD4 receptors will recognize those cells. Cytotoxic T cells, they have a CD8 receptor. They're only going to be activated by class 1 MHC. So if there was a cell that was infected with a virus, it can display those viral antigens on its cell surface, and the cytotoxic T cells can recognize it, give it the kiss of death, and take that cell out before that virus continues to replicate and goes out and infects other cells. We came full circle in this chapter in talking about immunization. And going back to that primary and secondary response, this is how vaccines and immunization works. So when we artificially introduce that antigen, that's when we're doing that primary response. In that secondary response, remember, it's supposed to be bigger and faster. So if we were to see that pathogen in real time, our body is going to be able to recognize it. We're going to be able to produce more antibodies and in a quicker time frame. Plus, remember, those antibodies are better at doing their job. So hopefully that helps to keep us healthy, or at least out of the hospital. Here you can see a couple of pictures of how vaccines work. And these pictures are talking about the mRNA vaccines and the SARS-CoV-2 virus. In the assignment that I had you do, I had you link to a paper that talks about how immunizations work, and mRNA vaccines were included in that as well. Now, we can be given antibodies, and remember, this is passive immunity. Now, the problem with giving antibodies is that this is kind of leaving the person vulnerable because they're not actively making those antibodies. However, if somebody is recovering from a disease, we could actually collect their antibodies and then give it to other people that are fighting the disease. I also mentioned that if, let's say that you had a needle stick, you can be given antibodies to basically go out and tie up those antigens before they do your body harm. Remember, natural passive immunity, the only way that we can see that is going from mother to baby. So usually when we're talking about passive immunity, it's artificially giving people those antibodies. The last thing that I talked about in this chapter is herd immunity or community immunity. This is made possible because of large-scale vaccination programs. So if more people in the population are immunized, that's not only going to keep people that are immunocompromised, that can't get vaccines, safe, but it also protects all of us. And I also posted that video that I played in class if you'd like to go back and review that video. It's only about a minute long, but I think it does a really good job of illustrating community immunity. Our last chapter is on what happens when our immune system kind of goes awry. So the first thing that we talked about were allergies. Allergies are when the immune system goes above and beyond. It's making an exaggerated response. We talked about type 1, which is immediate type 2, which is the cytotoxicity response, type 3, which has to do with immune complexes, and type 4, which is that delayed type hypersensitivity. So I captured this chart that illustrates all of those types of allergies. Now, remember, if you do have an allergy, it doesn't necessarily mean that it's going to fit nicely into one of these boxes. It could actually be a combination of these. It just depends on which part of our immune system is kind of going into that exaggerated response. Type 1 or immediate type, this is mediated by IgE, and this is when we get that release of histamine. Now, this is what we usually think of with a classic allergy, and this is also when people can go into anaphylactic shock, and that's because of that release of histamine. Usually, what we give if somebody is going into anaphylactic shock is going to be epinephrine, and that's going to counter the effects. Type 2 is cytotoxic, and this we see happening if somebody is given the wrong blood type. So if somebody has type A blood and they were given type B blood, those antibodies in their plasma are going to start to attack those B antigens on the blood that was introduced, and now they're going to have a huge inflammatory response. We also talked about this with Rh negative mothers that potentially could have an Rh positive baby, because then they can start making those antibodies that for subsequent pregnancies can then cross over and start attacking the baby's blood. Type 3, this is when we have immune complexes forming. And these big antigen antibody complexes, when they form, if they're not cleared, they can actually settle into places. Lupus would be an example of this. Sometimes lupus can be really difficult to diagnose because depending on where these complexes settle in the body, it can present in different ways. Type 4, this is that delayed type. This is often common with contact dermatitis. And sometimes it can be difficult to track because if somebody is having a delayed type reaction, they have to kind of think back of what they had actually been exposed to prior. So it can take, anywhere from 24 to 72 hours to see that reaction. So those are the different types of allergies. Another thing that we talked about were autoimmune diseases. So this is when we have hypersensitivity to our own cells and tissues. Now, there's a lot of reasons why we're seeing more autoimmune diseases. Some people think that maybe it has to do with epigenetics. Maybe it has to do with our environment. Maybe that some of those cells just kind of made it through that clonal deletion process. Another theory is that maybe we're just a little too obsessed with being clean. To me, it's almost like our immune system gets kind of lazy and then kind of turns on itself. So there's many things. I think it's more like a perfect storm than it is necessarily one thing. But autoimmune diseases, this is when our own body turns on our cells. Now, we talked about some autoimmune diseases, not all of them. We talked about things like Hashimoto's and Graves' disease, MS, also type 1 diabetes mellitus. There are many, many different types of autoimmune disorders. I don't expect you to know all of them, but just at least be familiar with some of those that we talked about. The other thing that we talked about, and this goes back to that MHC, and this is a transplant. So when we put tissue into somebody's body, we are going to have different MHCs. So the idea behind transplants is to try to match those MHCs as close as possible to kind of fool the body into thinking that it should be there. Now, usually people that have transplants, they will have to go on immunosuppressant drugs just to kind of temper down their immune system. We talked about the different types of transplants. Autograft, this would be like a skin graft. So going from one part of the body to the other, it's the same MHC, so there really is no chance of rejection. An isograft would be between identical twins. Identical twins are basically natural clones, so they should have the same MHC, so there's going to be less of a chance of rejection. An allograft, this is typically what we see where we have different people donating to somebody else. That's the most common. Xenograft we're hearing more about. This is tissue transplants between species. Now, rejections can happen at any time. They can be acute, where it happens immediately, or it could be something that happens years later. There's a couple of different types of rejections. The first that we typically think of is when the recipient's T cells see those antigens as being foreign, those antigens on the tissue, and they start to mount an attack. Graft versus host disease. This is when the T cells in the transplant kind of start attacking the tissue, and that kind of brings in the host immune system to have this big inflammatory response. Again, rejections can happen at any time. It can happen as soon as the transplant is done, or it can actually happen years later. I've known people to have lived many, many years with transplants without being rejected. The last thing that we talked about is immunodeficiency. So this is when our immune system is responding inadequately. So it could be primary or secondary. Primary means that the person is born with that defect. And we talked about that boy in the bubble syndrome, where somebody basically does not have an immune system. Secondary is normally what we see. This is more common, I should say. So if maybe somebody's malnourished, they're busy fighting other diseases. They have immunodeficiency from a virus like HIV, or maybe they have some other disease, or they're on immunosuppressants. So secondary is typically what we see more often. The last thing that we talked about is HIV and AIDS. So CD4 cells are the target of HIV. Now, if we bring down a T cell population, because remember, it's those T cells that are vital to having a healthy immune system, then we've basically depleted our immune system. And that's when it actually crosses over to AIDS. Now, being HIV positive isn't the death sentence that it once was. Now we have many drugs out there that can fight it. We talked about how HIV is a retrovirus, and how a lot of drugs are reverse transcriptase inhibitors. And there's a lot of other drugs and research that they've done over the years. Nobody actually dies from AIDS. It's from those opportunistic infections. So something that a healthy individual would be able to fight, people with AIDS that do not have a healthy immune system are not going to be able to fight it. All right. So that is an overview of our immune system. Again, make sure that you are practicing writing out those open response questions. As I always say, if you can explain it, then you know it.